morning everyone. Today I will be discussing the journal club topic silver diamine fluoride versus therapeutic sealants for the arrest and the prevention of dental caries in low income minority children. Study protocol for a crystal randomized controlled trial. It was published in the Journal of Trials with an impact factor of 5 in 2018. So I want to discuss some basic terminologies which are necessary for discussing this journal club. We already know silver diamine fluoride, a liquid dental treatment containing silver that kills the bacteria, and fluoride used to stop prevent tooth decay. Therapeutic sealants, protective coatings applied to the chewing surfaces of the teeth to block food and bacteria from causing cavities. Clustered randomized controlled trial. It is a study where the groups, not as an individual, the schools or the communities, rather than individual people, are randomly assigned to different treatments. Non-inferiority trial, a type of clinical study designed to show that new treatment is not worse than the standard treatment by a more or a smaller preset amount. So it doesn't compare the treatments, it just wants to see whether it is optimal to the other treatment and caries arrest, the healing of the tooth decay progression where activity becomes inactive for no longer worsening impact of the disease. So coming to the novelty, aims and objectives, it is a first large-scale school-based cluster randomized controlled trial comparing the silver diamine fluoride and the therapeutic sealants in preventing children and arresting caries in low-income minority children. Integrates real-world community setting into play, ensures the findings are applicable to the public health programs, and evaluates both the prevention and the treatment effects in a single protocol, which is uncommon to prior studies. So the aim of the study was to assess whether SDF is non-inferior to the therapeutic sealants that are given to the children in preventing and arresting dental caries in school-age children from undeserved communities. Objectives was to compare the rates of caries arrest between the SDF treated and the sealant treated teeth, compare the caries prevention rates in the sound teeth after SDF application versus sealant replacement, and evaluate the cost effectiveness and the feasibility of the SDF versus sealants in a school-based setting. Also determine if SDF application is more practicable and scalable to provide therapy when compared with sealants in public health outcomes. Coming to the materials and methodology, the study was centered in NYC primary schools with Hispanic and Latino populations, all coming from the low income group, all children with parental consent and child assist eligible. There were two arms in the study. First arm received, that is a simple prevention technique. They received 38% silver diamine fluoride and with NAF fluoride varnish, and the second arm, that is a complex treatment, received the glass ionomer sealants with interim therapeutic restorations for the cavities and 5% NAF varnish. Personal and delivery, the single arm was registered by the given by the nurses to the children and the dental hygienist, and the complex arm was given by only the dental hygienist, both supported by assistants in a dedicated school. The consumables and the kits, micro brushes, gauze, cotton rolls, and for isolation and drying, toothbrushes, and the fluoride toothpaste for the long-term effectiveness were given to the participants. Electronic tablets for data capture, data and instrumentation, visual tactile examination, child oral health impact profile for the short form, and the DOT posters for the academics were circulated, and attendance seen for the long-term effects for the 2 years and the 4 years. Methodology, when we come to the design, longitudinal pragmatic cluster randomized non-inferiority based trial for the randomized schools, care after every 6 months, spanning between 2018 to 2023, randomization and masking, block randomization at school level, treatment provides unblinded due to procedure nature, analysis planned with marks data set for arrest outcomes. Diagnostics, how they did it, teeth dried with gauze, full mouth visual tactile examination was done, caries status recorded using established diagnostic criteria, and intervention protocols. SDF arm was applied to the simple and the complex sealant arm to the other halves. Outcomes, When we see about the outcomes, when caries arrest at 2 years for the primary, prevention of the new caries at 4 years, calibration and standardization was done, ethics regulation was obtained. When we talk about the statistical analysis, tests used were generalized estimation equations to account for the clustering at the school level. Mixed effects logistic regression was used for binary outcomes, that is caries arrest or prevention, which happened after 2 years and 4 years significantly. Pre-specified non-inferiority margins set to SDF versus sealants. The parameters that were compared were primary caries arrest rates at 2 years, caries prevention rates initially from the sound teeth after 4 years. Secondary outcomes were child oral health impact profile scores and school attendance and standardized academic performance. Outcome, primary outcome was SDF was non-inferior to sealants for both caries arrest and prevention with the defined margin. And secondary outcome was oral health related quality of life improved in both the groups, and no statistically significant differences were there in the school attendance or the academic scores between the groups. So when we talk about the results, caries arrest, the SDF group achieved arrest rates comparatively to sealants meeting the non-inferiority criteria. Caries prevention, there were no significant differences between the two groups. Oral health quality of life for the short form scores improved similarly in both the groups. No measurable differences in the school attendance and academic performance of the students were evaluated. Safety profiles, when we talk about, is no serious adverse effects reported in either group throughout the study period. When we talk in percentages, in the SDF group, 56% of the cavities were treated and arrested. For the ART group, 46% of the cavities were treated with sealants and the outcome was done. Caries prevention, in the SDF group, 81% of the children had no new cavities, and in the ART group, 82% of the children had no new cavities. So essentially the similar outcome. When we talk about the tooth surfaces outcomes, 62% of the tooth surfaces treated in the SDF remained stable. 55% of the surfaces treated with ART remained stable. And SDF was slightly better compared to ART at keeping decay from progressing. Treatment failure, coming to the percentages, 45.5% failure in the SDF group and 53.3% failure in the ART group. So we know that fewer failures were there with the SDF group. Coming to the strengths of the study, it is a large-scale, long-term clinical trial with follow-up up to 4 years, providing robust longitudinal data, real-world school-based setting, enhancing generalizability of the results, cluster randomized trial design, minimizing contamination between the treatment groups, comparison of the both preventive and the arrest of the caries in the same study protocol, and inclusion of the secondary outcomes was done. When we talk about the limitations of the study, this cluster level randomization between the schools may introduce variability that is difficult to fully control when we compare about randomized control trials in the other ways. Lack of blinding for treatment providers and participants due to visible effects of SDF, so it was a major limitation. Potential loss to follow up over a 4-year period could influence the outcome estimates, and the specific demographic focus, low income, the Hispanic and the Latino group may limit applicability to the other populations. No cost-effective analysis reported in the initial findings despite being relevant to public health settings. When we talk about the study design guidelines, type of study design, pragmatic cluster randomized controlled non-inferiority trial conducted in school settings. So guidelines follows based on the consort extension for the cluster trials and the non-inferiority trials are clear statement of aim, study, hypothesis and non-inferiority margin. Detailed eligibility criteria for schools and participants was done. Randomization methods and allocation process described. Description of the interventions with standardized protocols was done. Clearly defined primary and secondary time outcomes with time points. Sample size calculation considering the clustering and the non-inferiority design was done. And the ethics approval was provided. Statistical method specified. what are the guidelines that were not reported or the partially reported. Blinding not feasible due to SDF, staining, acknowledged but not fully mitigated, no detailed adverse effects grading scale provided beyond general safe reporting, and limited discussion on the fidelity of the intervention delivery across all clusters was done. So coming to the future directions, what can be done in the further studies? Conduct cost-effect analysis between these groups and compare which will be the best for the limited resource setting populations. Expand the trials to diverse geographic and socio-economic populations for broader applicability. Investigate long-term caries recurrences rates beyond 4 years to assess any sustained effects are there or not. Explore combination strategies, SDF plus sealants, in this case for potentially enhanced outcomes, and study parent and child acceptance of the SDF treatment, especially regarding the anesthetic concerns like staining.